Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Courtney Smith. Today's episode features an expert discussion on screening for and identifying nonalcoholic steatohepatitis, also known as NASH, in the setting of HIV. This episode is part of a larger educational program titled Don't Forget About the Liver, NASH in Patients with HIV. During this podcast, Dr. Jürgen Rockstroh from the University Hospital Bonn in Germany will discuss his recommended approach to diagnosing NASH, as well as the role of non-invasive diagnostic tests such as serum biomarkers and elastography. In addition, he will discuss key differential diagnoses of non-alcoholic fatty liver disease, also known as NAFLD, in the setting of HIV. For more information on Dr. Rockstroh, along with CME-certified medical minute modules with downloadable slide sets and clinical thought commentaries from experts, please visit the show notes for this episode. Now let's get started and hear what Dr. Rockstroh has to say on this important topic.
The prevalence of non-alcoholic fatty liver disease, which we abbreviate with NAFLD, is higher in people with HIV than in the general population, ranging from 13 to 65% due to direct effects of HIV on the liver, weight and metabolic issues related to HIV treatments, and even metabolic comorbidities in our aging population. In addition, a substantial number of people with HIV, approximately 11.4%, also have non-alcoholic steatohepatitis, which we call NASH. In my opinion, the numerous reports on the development of NAFLD or NASH in aging people with HIV reinforce the importance of regular screening in people with HIV. To explore this, you must understand how NAFLD and NASH are defined. Now, NAFLD is defined as liver fat accumulation exceeding 5% of hepatocytes, either on imaging or on liver histology after the exclusion of secondary causes of fat accumulation in the liver. For example, significant alcohol consumption, certain medications, and other medical conditions. NASH is defined as the presence of hepatic steatosis and inflammation with hepatocyte injury, which we call ballooning, with or without fibrosis. Inflammation and ballooning in the liver, however, can be diagnosed only by liver biopsy. My approach, given the outsized impact of NAFLD and NASH in the setting of HIV, what is my approach to screening and diagnosis? After all, it's impractical to perform a biopsy to look for NASH in any people with HIV with liver enzyme elevation. In clinical practice, non-invasive diagnostic tests, such as serum biomarkers and transient elastography, may help identify patients with NASH-related fibrosis who will then require further workup. The European AIDS Clinical Society guidelines include a diagnostic flowchart to assess and monitor disease severity in people with HIV and suspected NAFLD and metabolic risk factors. In the flowchart, ultrasound is the preferred first-line diagnostic procedure for imaging of NAFLD. If an ultrasound suggests NAFLD, the guidelines recommend determining the risk of advanced fibrosis by calculating FIB-4 or NAFLD fibrosis score, two scoring systems that are based on readings we already collect in the regular care of people with HIV. FIB-4 is based on age, aspartate aminotransferase, platelets, and ALT. NAFLD fibrosis score is based on the same parameters, but includes albumin, BMI, and presence of impaired fasting glucose or diabetes mellitus. We're available and in experienced centers, imaging through transient elastography with controlled attenuation parameter can be used to diagnose HIV-associated NAFLD. Although no optimal cutoff has been established, a few studies have validated a controlled attenuation parameter cutoff specifically in HIV-associated NAFLD using specific values of 248 decibel per m or 285. What next? Based on the level of hepatic steatosis and presence of concomitant fibrosis, a risk stratification can be performed, including referral to the hepatologist and potentially a liver biopsy in individuals with signs of advanced fibrosis. Performing this sort of NAFLD assessment and metabolic risk factor determination also enhances clinical management decisions, allowing for early initiation of interventions such as lifestyle changes and potential pharmacologic interventions. Early interventions targeting lifestyle and weight control can help prevent more advanced courses of NAFLD or NASH in this at-risk population. Although the best validated non-invasive tool for NAFLD screening remains unclear, to me it is clear that screening can have a significant clinical impact and prevent a more severe disease course. In fact, EACS guidelines recommend a NAFLD rescreening and risk assessment every 2 to 5 years, depending on clinical risk.
Thank you very much, Dr. Rockstroh, and thank you to the listeners for joining us. As a reminder, to view the full program and to join the discussion, please click on the link in the show notes. As always, thank you for listening.